Hello everyone, welcome to the new chapter Hemodynamics. So hemodynamics I will be dealing in various parts. Today we will be just brushing up some of the very basic concepts that we have already read in physiology, that is the normal flow of blood, about the coagulation cascade, primary and secondary hemostasis. Okay, fine. So let us start. See, as far as hemodynamics is concerned, the very first thing you have to know what is hemostasis. Hemostasis is nothing else but the process of blood clotting which prevents excessive bleeding after a blood vessel damage. Suppose if a blood vessel undergo damage, in order to prevent the loss of blood, the body has to control the bleeding. That is hemostasis. Suppose whenever there is a inappropriate clotting, so this is a vessel wall, and suppose there is an injury here, the platelets will start aggregating. This is what we call it as primary hemostasis. Suppose if there is an abnormality, so this is primary hemostasis is normal. Suppose if there is more aggregates of platelets, what will happen? This will altogether form what we call it as thrombus. Okay, so this is, suppose it is happening in the periphery. Okay, suppose this is happening in your lower limb. I am writing here lower limb. Suppose, so we have the lungs here. Okay, I am going to draw the trachea, and we have the lungs here. Okay, so from the lower limb, this thrombus may reach lungs, it may reach heart. So that is dislodgement. That is what we call it as embolism, migration of clots. Suppose this clot may reach some of the cerebral vessels, okay, cerebral vessels in the brain, and this may cause occlusion of arteries, and that is what we call it as infarct. Already we have discussed infarct, coagulative necrosis. So here we will be discussing the different types of infarct and all. So this is the basic terminologies you have to know. What are the terms? Number 1 is hemostasis. Number 2 is embolism and thrombus. And number 4 is what we call it as infarction. Okay, infarction. So this infarction is responsible for that myocardial infarction, or these are sudden death. Am I right? Pulmonary embolism, cerebrovascular accident or stroke. So these are all very sudden events. Okay, let us see the normal hemodynamics. What is edema and what are effusions? Edema means, remember children, it is an accumulation of fluid in the tissues. At the same time, if that fluid accumulates in body cavity, pleural, pericardial, peritoneal, we call it as effusion. Okay, pericardial effusion, pleural effusion, peritoneal effusions. Fine, yes. So what are the reason for this edema? Normally what will happen? There is something called as hydrostatic pressure and plasma oncotic pressure or plasma colloidal osmotic pressure. Normally, this hydrostatic pressure by the vessels and the plasma colloidal osmotic pressure both will be going hand in hand. They will balance each other. Whenever there is a problem in this, that is, whenever there is an elevated hydrostatic pressure or decreased colloidal osmotic pressure, what will happen? This balance will be disrupted, which will result in increased movement of the fluid out of the vessels. Fine? Yes. And these edema fluids may be two types. One is inflammatory, another one is non-inflammatory. Inflammatory, I have already explained in detail in the chapter inflammation. Am I right? That is inflammation related edema. These inflammation related edemas are called as, yes, can you tell what it is? They are exudates. They are exudates. Whereas non-inflammatory, so exudates, no, they are protein rich. Exudates are protein rich. Whereas transudates, they are non-inflammatory, they are protein poor. They are protein poor. In this chapter, we will be mainly focusing on transudate, which occurs in conditions like heart failure, in liver failure, renal disease and malnutrition. I hope things are very clear for you. Okay, let us focus on this picture. See, normally from the vessel wall, you will have hydrostatic pressure and back in return we have something called as plasma colloidal osmotic pressure. This is exerted by the proteins, plasma proteins. We have no albumin, yes, lot of plasma proteins we are having, albumin, globulin, yes. So all these will be exerting pressure. So these will be going hand to hand, they will balance each other. As a result, there won't be any edema. Whenever there is a problem here, what will happen? There will be excess fluid accumulation in the tissue, we call it as edema. Excess fluid accumulation in the body cavities, we call it as effusion. Okay, yes. So now let us see what are the various causes of edema. Various causes of edema. Fine, yes. Number one, increased hydrostatic pressure. When the hydrostatic pressure is going to increase, what will happen? There will be poor venous return. So here you can focus on this table. This focus is, if you write this table, this is more than enough. Okay, just focus on this table. Fine, yes. So we have various causes. Number one cause, children, that is increased hydrostatic pressure, which will cause either, it is because of either impaired venous return or because of arteriolar dilation. Okay, this is one. In that you have A and B. A is impaired venous return in case of congestive heart failure, constructive pericarditis, liver cirrhosis, in case of thrombosis, DVT, deep vein thrombosis. Okay, yes. And in arteriolar dilation, okay, suppose in case of non-ambulatory patient, that means after post-operative, you will see the patients will be lying on the bed, supine position for a very long period. They will be immobile. So what will happen? There will be pooling of the blood in the lower limbs. So which is a very it's a very life-threatening condition. That is the reason the surgeons will advise the patient that you should move your legs. Am I right? Yes, because there will be impaired venous return. This blood will undergo pooling. This blood will undergo thrombus formation. It will dislodge immediately to heart or lungs, which will cause life-threatening pulmonary embolism or myocardial infarction. Then arteriolar dilatation due to any heat or neurohumoral dysregulation. Then that is the first cause. The second cause is nothing else but reduced plasma oncotic pressure, that is hypoproteinemia. When the plasma proteins are less, in what condition? Liver cirrhosis, in malnutrition, protein losing glomerulopathies, nephrotic syndrome. Nephrotic syndrome means the protein will be lost through urine, or protein losing gastroenteropathy. What is that? Protein losing gastroenteropathy. Then third cause is lymphatic obstruction. Lymphatics is also one of the plays a very vital or a crucial role in maintaining the balance. Okay. Yes, it prevents the edema formation. Whenever there is lymphatic obstruction due to some inflammatory neoplastic, inflammatory causes and all, elephantiasis and all, there will be lymphatic obstruction. Yes. And the fourth cause is sodium retention, that is excessive salt intake. If the patient's kidney is not working, but still the patient is taking more salt, what will happen? There won't be any proper excretion of the sodium salts and all. So what will happen? There will be excessive, that is hypertension. One of the most important cause for hypertension in our country is excessive salt intake. Then in case of increased tubular reabsorption of the sodium, am I right? See, normally the sodium, some amount of sodium has to be excreted in the urine, but whenever there is an increased absorption of the sodium, what will happen? Again, that will cause a sodium retention or increased RAS secretion, renin-angiotensin, aldosterone secretion. Then fifth cause, inflammation, acute chronic inflammation as well as in angiogenesis. So these are the conditions, that the same thing only they are discussing here in paragraph. Okay. So rather than going for that normal paresy, lymphatic obstruction, inflammatory condition, you can go for filariasis. Okay. Yes. Please. Okay. This table is VIP. Okay. Very, very important table. Please focus on this. Okay. Once this is done, let us see how the mechanisms, in heart failure, renal failure, hepatic failure, all these conditions, how the edema occurs. Okay, please focus on this flowchart. Okay, I'm repeating again. Please focus on this flowchart. This flowchart is very important. Okay, yes. Fine. In heart failure, what will be happening? Capillary hydrostatic pressure will be increasing, or there will be decreased renal blood flow. Both will cause activation of the renin-angiotensin mechanism, sodium water retention. Okay, even renal failure will also have the same mechanism, which will increase the blood volume. So more fluid will be pushed outside into the tissue. In malnutrition, nephrotic syndrome, what is the mechanism? In heart failure, renal failure, the problem is increased capillary hydrostatic pressure. Whereas in case of malnutrition, hepatic failure, nephrotic syndrome, all this, what is the problem? Decreased PP, plasma proteins. Okay, decreased plasma proteins. So decreased plasma albumin, decreased plasma oncotic pressure, which will finally cause edema. Fine? Yes. Okay. Yes. Now let us see what are the different types of edema. Different types of edema. Okay. Number one, subcutaneous edema. Subcutaneous means what? Yes, just below the skin, the edema will be present. This is most commonly seen in tissues like lungs and brain. Straight MCQ question. Subcutaneous edema is present in brain and lungs. Okay, yes. Then second is what we call as dependent edema. That means on the dependent positions of the body because of gravity, they are sacrum, and as well as in the legs we will have dependent edema. Sometimes the finger pressure over this edematous tissue, it will displace the fluid and it will leave a depression. Okay, suppose in a patient who is having congestive cardiac failure, please, if you go, okay, when you are going to the clinics, please go and please press over the dorsum of the foot or the medial aspect of the leg. What you can see, once you press and you leave it, you can see there is a pitting, there will be a depression. So that is what we call it as pitting type of edema. Whereas in case of elephantiasis, that is one of the important way how you can differentiate. In elephantiasis also there will be edema, but it will be usually a non-pitting type of edema. Fine. Then we have something what we call as renal dysfunction. Renal dysfunction, it is periorbital edema. See, this is a very important characteristic feature of severe renal disease. In severe renal disease, there will be periorbital edema. Okay, yes. And of course, you will have pulmonary edema, brain edema, okay, and you have lot of effusions. What are they? Hydrothorax, hydropericardium, hydroperitoneum, or ascites. Am I right? Yes. Remember, all these type of effusions are transudate. Very, very important MCQ question. This has been asked in PGI. All of the following are they will give inflammatory or non-inflammatory edema. So you have to find out what are transudate, what are exudate. Fine. This pericardial, pleural, peritoneal effusions, all these are transudate. They are non-inflammatory. Non-inflammatory means what? They are protein poor. Whereas exudative effusions are protein rich and they have high amount of white cells, WBCs. Fine? Yes. So, clinical features, how the patient will present with. If there is any problem in the respiratory system, the patient will present with difficulty in breathing, that is dyspnea, breathlessness, cough, all those. In cardiac condition, the patient will have exertional dyspnea, okay, that is dyspnea on walking, okay, and yes, in renal failure, there will be oliguria, hypoxemia all occurs in case of CVS and RS pathologies. Fine. And in peritoneal effusions, you can see there will be portal hypertension, associated portal hypertension. So all these are the clinical features. And please, okay, so what is the clinical correlation here? I am writing the clinical correlation here. Okay, how you have to observe in clinics. Please, number one, go and observe a patient with CCF, congestive cardiac failure, and please elicit pitting edema, okay, pedal edema. Number two, in RS pathology, COPD, okay, or in acute respiratory distress syndrome, okay. Then number three, ascites, okay, ascites. Number four, liver failure. Ascites you can elicit through, we have a lot of tests, fluid thrill, shifting dullness, fluid thrill, if there is more amount of fluid, if the fluid is very less, we can go for shifting dullness. So please, these are the clinical correlates, okay. Please, when you get time, please go to the clinics, and in these patients, please try to appreciate these findings, okay. This is how you should apply pathology to your clinical subjects. Fine. And please see what are the clinical please see the clinical features. So that only will help you to retain these things in your mind rather than mere reading from the textbook. Okay. Now let us see two important terminologies. One is called hyperemia and another one is congestion. First of all, understand that hyperemia and congestion both are because of increased blood volume. Whereas hyperemia is an active process. Congestion is a passive process. Hyperemia means the problem is in the artery. There is more arteriolar dilation. For example, during exercise there is increased blood supply to the skeletal muscle. That is actually because of hyperemia. So, as a result of hyperemia, because of increased delivery of oxygenated blood, how will be the affected tissues? The affected tissues will be turning red. Erythema. Erythema means it is a result of hyperemia. Don't say erythema and hyperemia are same. Hyperemia is the process. Erythema is what we are going to appreciate. Congestion is a passive process. Why it is called passive process? Because the problem is in the venous outflow. That is, there will be problem in the venous drainage. Am I right? It may be caused because of any systemic causes, any cardiac causes, or maybe due to any venous obstruction. So what will happen? That is, the blood won't drain. It won't go back to the heart. The deoxygenated blood will accumulate there. So what will be the color? It will be blue-red color. That is cyanosis. So C4C. C4C. That means congestion means cyanosis. Congestion means cyanosis. Okay. Congestion means cyanosis. Okay. I will write it again. C4C. C4C. That is congestion means cyanosis. Cyanosis means blue red color, whereas erythema means reddish. Fine? Yes. So this cyanosis occurs, we have different condition, that is chronic passive congestion of liver, we have chronic passive congestion of the lungs. Okay, so these are the two conditions that I am going to discuss here. Okay, so congestion means, always remember, it is because of what? Accumulation of deoxygenated hemoglobin in the affected area. Fine? Yes. And what will happen? Chronic congestion. So the blood is standing there for a long time. Capillary rupture. Small hemorrhage. Red blood cells will come out. These red blood cells will what? Come out. Hemoglobin will reduce. Finally, hemosiderin laden macrophages. So all this what lies to RBCs will be engulfed by what we call it as our macrophages. So that is responsible for hemosiderin production. All those, and all this hemosiderin is the main culprit. Hemosiderin is the main culprit for the brownish red color of the skin there. Okay, brownish red color of the skin. This is straight away MCQ question in your clinical. Okay, they will straight away ask you why that pigmentation. That pigmentation of the skin is because of hemosiderin what? Deposition. So the red blood cells will come out and what? It will get converted into hemosiderin. This is very, very important question in cases of peripheral vascular diseases. We call it PVDs. Okay, which are arterial as well as venous disorders. We have in arterial disorders, in peripheral what? Arterial occlusive diseases. What? There will be, you can see if you go to surgery ward and if you see any PVD patient, you can see, ask them to stretch out their arms, upper limbs or lower limbs, you can see hyperpigmentation because there is what? Accumulation of deoxygenated blood as well as due to ischemia. That is, the oxygenated blood is not reaching there properly. Now let us see the morphology. In congested tissue, I have already told that it is a dusky reddish blue color. Cyanosis because of presence of deoxygenated hemoglobin. We have chronic pulmonary congestion and chronic hepatic congestion. Okay, yes, both these are spotters. Both these are spotters for your university exam. In your practical session, I will be dealing with this a bit more detail. Now pertaining to theory. So we have acute pulmonary congestion, chronic pulmonary congestion and acute pulmonary congestion. Acute pulmonary congestion means what? For a short duration of time. So what will happen? There will be dilated alveolar capillary, the alveolar septal edema will be there and focal hemorrhages. Okay, hemorrhage will be only present at some few sites. There is in chronic pulmonary congestion, remember the chronic pulmonary congestion, I am writing separately, chronic pulmonary congestion, it is usually a sequelae of heart failure. It is usually a sequelae of what? Heart failure. Fine? Yes. Congestive heart failure. So what will happen? The septa will be thickened. It will undergo fibrosis because chronic. See, now only you have to start applying your basics of cell injury, basics of inflammation here. So chronic. Chronic means thickening, fibrosis. Okay. Macrophages laden with the hemosiderin. And this macrophage laden, okay, or I am saying hemosiderin laden macrophages. Hemosiderin laden macrophages. These hemosiderin laden macrophages are what we call it as heart failure cells. Heart failure cells. They are also sometimes called as dust cells. Remember, these are found in lungs or heart? Lungs. So in MCQ question they will ask, okay, please open your eyes here. Heart failure cells. Why it is called as heart failure cells? Because this pulmonary congestion occurs because of the heart failure. As a result, the alveolar macrophages will engulf this hemosiderin and all other particles, and finally it will get converted into heart failure cells. Okay, also called as dust cell. This is a hallmark feature of, okay, why it is called heart failure cells? I told you because of the congestive heart failure it is this, and this heart failure cells will appear what? Darkish red in color. Okay, darkish red in color because of the engulfed RBCs. Engulfed RBCs. Okay, I hope it is very clear for you because of the engulfed RBCs. Okay, yes. Now let us see what happens in hepatic congestion, that is chronic venous congestion. So these are the two conditions, children. Okay, these are the two conditions I am writing here. One is what we call chronic venous congestion, that is CVC, lung. That is I have explained here. And next is CVC liver. Next is CVC liver. I am going to explain it. Okay. So what happens in CVC liver? Again, if it is acute hepatic congestion, we have the central vein and sinusoids which will be distended. Am I right? Yes. There will be centrilobular necrosis. Centrilobular necrosis. Here comes an MCQ question. Okay, here comes an MCQ question. Acute hepatic congestion, bracket, hallmark feature. Hallmark feature. Answer, centrilobular necrosis. Answer, centrilobular necrosis. I hope things are clear for you. Yes. Now let us see what happens in chronic venous congestion. In chronic congestion, again, these centrilobular regions, no, fine, they will be what, it will be more prominent, and at the same time they will become more reddish brown in color. Reddish brown in color. Fine. Since it is chronic, no, again, like our chronic inflammation, what will happen? They will undergo accentuation. Fine. And it will finally give rise to a characteristic appearance called a nutmeg liver. See, you can see in chronic, why it is called as a nutmeg liver? Because it appears like a cut surface of a nutmeg. You have seen, no, nutmeg? Yes. So you can see here, no, this I am putting dots. These are the nutmeg liver. Why it is called the nutmeg liver? Because it appears like a cut surface of a nutmeg. So this is how it looks like. There will be a central reddish area. There will be a central reddish area and it will be slightly depressed. This will be slightly depressed. And surrounding that you have the normal liver. Normal liver. That is why this is called as a nutmeg liver pattern. Nutmeg liver pattern. See, in microscopy you can appreciate the centrilobular. See, these are the normal. This is normal. I am marking it as N. Whereas I am drawing this. Okay, see, in this you can see this is centrilobular necrosis. These are central vein. These are central vein. Okay, with degenerating hepatocytes and hemorrhage. So nutmeg liver. It's a straight away MCQ question. Straight away MCQ question. In CVC liver, nutmeg liver. Okay, nutmeg liver. Why it is nutmeg? Because it appears, looks like an cut surface of a nutmeg. That means you have to explain there will be a central reddish area. Central reddish area of necrosis surrounded by viable means normal liver parenchyma. This is how you should define. You can't say, okay, it looks like the appearance of nutmeg. So you have to correlate. Why nutmeg? Because central followed by surrounding by a normal or viable liver parenchyma. So this is a characteristic finding. And of course in microscopy you can see centrilobular necrosis, congestion. You can also write hemosiderin laden macrophages. So hemosiderin laden macrophages, you can write for all chronic venous congestion. Okay, yes, I told why hemosiderin laden macrophages, because what, the blood undergo stagnation for a very long period of time, the capillaries undergo rupture, RBC comes outside, then macrophages come and engulf, hemoglobin breakdown, hemosiderin deposition. Fine, yes, so that is the pathology. Okay, fine. So once this is done, so I hope this is very clear for you. Once again I am telling, I will be having a separate session. Okay, I will be having a separate session, separate practical session on CVC liver and CVC lung. We will discuss a bit more detail there. Fine. I hope it's clear for you. Fine. Yes. Now let us see. The normal hemostasis. Here I am going to just brush up the few concepts that you have already studied in your first year, that is in your basic physiology. Fine, I'm going to just brush up because why? Because the normal hemostasis, that is the primary, secondary hemostasis, again this will be discussed in detail in hematology. In hematology, we will be discussing again this in detail. So I'm just going to explain rough. Fine, normal hemostasis. First, there will be arterial. I'm just going to highlight the important point. There will be arteriolar vasoconstriction. Primary hemostasis mainly by platelet plug formation. We have von Willebrand factor. This von Willebrand factor will what? And the collagen will promote platelet adherence and activation. Secondary hemostasis, that is activation of the coagulation pathway, that is the clotting pathway. And finally, this is because of the tissue factor. Tissue factor will be exposed. This will activate the coagulation cascade that will be producing secondary hemostasis. And fine. This tissue factor will further activate factor 7. We have two pathways, extrinsic and intrinsic pathway. Finally, fibrin deposition, which will be an insoluble fibrin. Fibrin is stabilized by clotting factor 13. Finally, we call it as secondary hemostasis. Finally, clot has to be formed. It has to be what? Resorption. Clot resorption. That is, we have some counter regulatory mechanism, that is TPA, tissue plasminogen activator. Fine, which will causes resolution, which will dissolve the clot, and finally what? Clot resorption will occur. See, I will just focus on the picture. You can see here, this is the site of injury. Fine, I am just making it a fast because as far as hemodynamics is concerned, this is not that much important because we will be discussing each and every step in detail in hematology, bleeding disorders, okay, platelet disorders. That's a different chapter we will discuss in detail. But since Robbins, they have mentioned it here, I'm just making it brush off. Okay, no extra other points. What you have learned in your physiology, blood physiology only, I'm going to revise it again. Site of injury, there will be first aid, what? Vasoconstriction. Vasoconstriction will be mainly because of endothelin. Endothelin is the most potent vasoconstrictor in the body. Most potent vasoconstrictor in the body is endothelin. Endothelin. Okay, I'm writing here also. Endothelin. Most potent vasoconstrictor. Most potent vasoconstrictor is endothelin. Endothelin is the most potent vasoconstrictor. Fine. Once that is done, finally, clot dissolution, all those will happen. So what is actually normally happening? There will be a balance between prothrombotic activity and antithrombotic activity. What do you mean by prothrombotic? That is, which will favor the platelet aggregation. Antithrombotic means what? Finally, I told the clot resorption will happen. So there will be always a balance between these two. Once there is a problem here, what will happen? Of course, thrombus, embolus, all this will happen. So platelets, we have two types of granules in platelets. Okay, we have alpha granules, okay, and dense granules. Alpha granules have, okay, I'm just mentioning that alpha granules have fibrinogen, coagulation factor 5, and von Willebrand factor, as well as fibronectin, platelet factor 4. Fine, platelet derived growth factor, transforming growth factor beta. Very important MCQ. We will discuss it again in hematology, but I am telling very important MCQ. One MCQ from this every year must in PG entrance. Dense granules contain ADP, ATP, calcium, serotonin, and epinephrine. Okay, that's again an MCQ question. So in this picture, you can see there is a vasoconstriction. Then what will happen? The von Willebrand factor and the collagen. Von Willebrand factor, collagen, all this will have what? That is platelet recruitment, platelet adhesion, aggregation, all those stuff. That is primary hemostasis. Then the exposure of tissue factor will leads to what? The coagulation cascade activation. Finally, this will cut fibrin deposition and fibrin polymerization. So then we have the antithrombotic events, that is the release of tissue plasminogen activator, which will cause fibrinolysis, and we have thrombomodulin, which will block the coagulation cascade. These are the antithrombotic events. So normally there will be a balance between thrombotic and antithrombotic events. That is why we are what? So blessed. We are so lucky. We don't have any thrombus or embolic episodes. Fine. Now let us see how the platelet adhesion. The platelet will adhere to collagen via the receptor called glycoprotein 1A, 2A, or we have something called glycoprotein 1b9 receptor. So there is a deficiency. We have lot of condition, von Willebrand disease, Bernard-Solier. If there is, and the platelet aggregation is mainly because of glycoprotein 2b3a. That is, the platelet will attach to another platelet with the help of glycoprotein 2b3a receptor. Whenever there is a deficiency of that receptor, we have some condition called as Glanzmann thrombocythemia. I'm not going to that and all because that and all is a different topic. Okay, if I start talking, okay, it will go like anything. So I'm not going to touch all this because it's in hematology. We have to write again. We have to start from the basic. We will be discussing the clinical features, everything. Okay, so glycoprotein 2b3a, that helps in platelet aggregation, whereas platelet adhesion with the collagen. Okay, and via the collagen, not only the collagen, with the von Willebrand factor, that is by glycoprotein 1b9 receptor deficiency leads to what we call condition called the Bernard-Solier disease. Fine, Bernard-Solier disease. Then fine, see, glycoprotein 1b deficiency, we have Bernard-Solier, 2b3a, Glanzmann thrombocythemia, and von Willebrand factor deficiency, we have von Willebrand disease. Fine, okay, I'm not going to that and all now here. So that's it. Fine, and you know what are the factors which activates? That is thromboxane A2. That and all I have already told you in the inflammation. Please watch my video on the chemical mediators of inflammation. Chemical mediators of inflammation. Please watch that video. Okay, very important. It's an essay question for you for your prof exam. You will get short note, and of course the concept of this chemical mediators is very important. If you are thorough, that only is coming in hemodynamics. Fine, yes, you should know what is PGI2 do. PGI2 means it will inhibit platelet aggregation. Thromboxane A2, A4A, I told you know, A4A. That means A means thromboxane A2. It will promote, it will favor platelet aggregation. Fine. Then we have the coagulation cascade. Of course, we have the intrinsic pathway because of the negatively charged surface. Extrinsic pathway is because of the tissue factor. Finally, which will lead to fibrinogen, fibrin clot formation. I'm not going to touch any of those things because that is a different topic. In hematology, we will be discussing each and every step in detail. Then we have some of the anticoagulation mechanisms also, okay, and how we are going to, then what are the vitamin K dependent clotting factors, they will ask you 2, 7, 9, 10, 2, 7, 9, 10. Okay, of course these and all again we will discuss in hematology. Then we have prothrombin time to assess the extrinsic pathway and partial thromboplastin time to discuss the to determine the function of the intrinsic pathway. Fine, yes. Then what else? Yeah, see, this is the fibrinolytic system. We have the plasmin, antiplasmin, am I right? Then TPA, tissue plasminogen activator, PI, plasminogen activator inhibitor. So all these are the fibrinolytic system, okay, or the antithrombotic system. And finally, they will dissolve the fibrin clot and convert them into fibrin degradation products. Fine, yes. So again, we have a lot of abnormalities in that. So if there is normally there is a balance between the thrombotic and antithrombotic mechanisms. Fine, yes. So this balance between, so I'm not going to fibrinolytic mechanisms and all those. I told you again it will be discussed in detail in the hematology chapter. Fine, yes. And let me tell, before finishing this session, let me tell you. So this session is like more or less like a revision from your basic physiology. I have not done any pathology except CVC liver, CVC lung. That is the only pathology topic I have discussed today. The rest of the topics I have discussed is hemodynamics. Okay, rest of the topics what I have discussed is your normal physiology. We have discussed about what is edema, what is infusion, the causes. Okay, please focus on this table again. Fine, and the clinical features. Then I have told you what is hyperemia, congestion, how to differentiate between these two, CVC liver, CVC lung. Then normal hemostasis. Please, okay, if you don't feel comfortable by reading the normal hemostasis, of course it's. We will discuss that in hematology in detail again, but still if you feel that you have to brush up your topic, please go to your physiology, blood physiology textbook, take Gaitan or Ganong or GK Pal. Please go through that textbook and please read the normal, primary, secondary hemostasis as well as the fibrinolytic system. So that will finish as the very basic. Okay, you will get an idea also, and please watch my lecture on the chemical mediators of inflammation. Please read the very important flow chart of the arachidonic acid metabolites, what they will do. It is given in Robbins. Please go through that flow chart because you will there only. It's very beautifully mentioned each chemokine or the cytokine, what they are going to do on the vessels, what they are going to do on the platelets, everything is very beautifully mentioned. Fine. See, normally I told you there will be a balance between thrombotic and antithrombotic episodes. Fine. So the balance between the anticoagulant and the procoagulant activity, it only will determine whether there should be any clot formation or whether this clot will undergo propagation or dissolution. So normal endothelial cells will express a lot of factors. Yes, I told you, thrombomodulin. This thrombomodulin is going to what to say? Yeah, the thrombomodulin is there, and this thrombomodulin is going to block the coagulation cascade. Similarly, we have lot of factors which will be expressed by our endothelial cells, which will prevent the clot formation. Am I right? Yes. So, what are those normal properties or the antithrombotic properties of endothelium? What are the normal antithrombotic properties of endothelium? Number one is called platelet inhibitory effect. Normally, some compounds will be produced from the healthy endothelium, which will inhibit platelet aggregation. What are they? Fine? Yes. 3 important names. Number 1, PGI2. Prostacyclin. Inhibit platelet aggregation. Number 2, nitric oxide, also called endothelial derived relaxing factor, EDRF. Number 3, adenosine diphosphatase, because ADP will favor platelet aggregation. This was a question in PGI. ADP favors platelet aggregation. Am I right? Yes. So this is adenosine diphosphatase. So it will go and degrade ADP. Fine? Yes. So these are the 3 compounds you should remember. Once this is done, there are some anticoagulant effects. Number 1, thrombomodulin. Inhibit coagulation cascade. I have told you already. Heparin-like molecule. Tissue factor pathway inhibitor. TFPI. Fine. Then endothelial protein C receptor. Protein C, protein S, they are all part of fibrinolytic system. So they are also going to exert anticoagulant effect, as well as heparin-like molecule. Heparin is a natural, it's an inborn, within our body itself produce an anticoagulant, that is heparin-like molecules. So tissue factor pathway inhibitors, because it is the tissue factor which is going to trigger the secondary hemostasis. So tissue factor pathway inhibitors. Number 2, endothelial protein C receptor, bind with protein C, protein S, fibrinolytic mechanism. Number 3, heparin-like molecules. Number 4, I told you, what is it? Thrombomodulin. What the thrombomodulin will do? It will inhibit coagulation cascade. In detail, we will see in hematology. So these are the normal ways in which, this is a short note question for you. I am writing it here. This is a short note question for you. How the normal endothelium prevents what? Or what are the antithrombotic properties of endothelium? Straight away short note question. You are going to write the platelet inhibitory effect and the coagulant effect. Fine? Yes. So I think with this I am going to finish this session. So we have discussed the very basics. Please go back as far as path is concerned: hyperemia, congestion, CVC, liver and lung. Then what are the categories, causes, pathophysiological causes of edema, effusions, what is difference between transudate, exudate. Fine, these are the things we have discussed today. Nutmeg liver, heart failure cells or dust cells. Then rest is primary, secondary hemostasis. Of course, it has nothing to do with hemodynamics, because again we will discuss in detail, step by step, in detail, all the right from the basic physiology we will start reading from our hematology. But here, okay, yes, just if you are interested, please go back to your physiology, because Robbins, he has mentioned only some few points. He have skipped many things. Go back to your basic physiology, GK Pal, Guided Organa, and revise those topics if you are interested, or else no issues. We will see again these topics in hematology. Okay, fine. So I hope this session has been useful for you. Thank you.